Hello, this is my oral maxillofacial presentation on an arch bar application procedure. So what is an arch bar application procedure? It involves the placing of thin, malleable stainless steel metal strips and interdental wiring applied to the teeth to stabilize and immobilize the jaw following a maxillary or a mandibular fracture. It is placed for occlusion and jaw immobilization, and it is most likely performed prior to a whole slew of other jaw surgeries. Um, it just one good example would be an open reduction of the jaw. So the anatomy that would be involved in this procedure would obviously be the teeth, the alveolar process and bone, periodontal ligaments and muscles, the maxilla and mandible bones, and your gingiva, which is just basically your gums. But the specific anatomy as for which teeth are involved, which parts of the jaw are involved, that depends on the type of fracture that the patient has and the severity of it. So there's only one general indication for this procedure, and that would be a fractured jaw. There are four main types of different fractures: a symphysis or a parasymphyseal fracture. So this image and this image would be a symphysis fracture. This image would be a parasymphyseal fracture, and yeah, obviously a fractured jaw comes from a major trauma. It has to be an incredibly strong force to break the jaw. So obviously, dental trauma. So preoperative diagnostics, obviously physical exam and history, a panoramic x-ray, a CT scan, or a 3D dimensional or 3D imaging. That is for reconstruction. That is for pretty severe cases. Panoramic x-ray and a CT scan. This is what a 3D imaging would look like. This is a mandibular angle fracture. This one is a ramus horizontal, as you can see right over there where these arrows are pointing. This is before and after a reduction. Normally, the arch bar application procedure is performed in at the most 7 days after the injury, but most of the time it's pretty emergent. So there really isn't a lot of time for things like an MRI or 3D imaging. All right, surgical counts. So surgical counts, you're going to do your initial count in the back table when you're setting up the back table. The first closing count, I put quotes around the closing count because during this particular procedure, there is no actual incision, so you're not closing anything. But as the surgeon finishes up, you should count. And once the surgeon is done, you obviously want to count one more time. Make sure that any wire that has been clipped is nowhere near the patient's mouth, not in the patient's mouth. You're going to do extra counts if there's a change of personnel or something is lost, and you are only counting sponges, sharps, and extras because you're not entering a body cavity. So positioning and positioning aids, the patient is going to be in supine with their arms tucked. Their head will be tilted back and a rolled towel will be placed underneath their neck to hyperextend the neck a bit. There will also be a donut or foam headrest. The surgeon typically stands at the head of the bed, obviously. So the table will probably be reversed for anesthesia. Prepping and draping. So this is considered a clean procedure, not a sterile one. So typical prepping does not really go on, which is I read through it all. I could not find any specific skin prep, but there is antiseptic mouthwash that is used, a throat pack, and then for draping, typically a turban style head wrap or a U-drape and then a half sheet is probably going to be placed over the patient's body as a sterile field to place instruments on them. And then for the incision, there's no incision employed for an arch bar application because the wire is threaded through the gaps in your teeth, but an incision probably will be made later for a different surgery following the arch bar application. All right. So for your instruments, you're going to have your minor ortho tray, your tracheostomy tray. You're going to have that available simply because it's so close to the airway that you never know. And you're going to have your dental extractions tray. For the tracheostomy tray, you're going to have that. They might decide to do a trach, but it's more preferred to do a nasal intubation for oral maxillofacial procedures. And then, okay, so for the equipment, your CSDs, a dental ESU, simply because there is a greater fire risk and, you don't want to damage. Fiber optic headlight or loops for the surgeon. Suction, a dental drill, that's it depends on the procedure. A facial nerve monitor, once again, depends on where you're going. Typically not used for arch bar application, but I did want to include it. So supplies, your antiseptic mouthwash, ophthalmic ointment for the eyes, ointment for the lips, a throat pack, ESU, pencil, suction tubing, grounding pad, sterile water. So nothing too out of the ordinary. The defogger for the dental mirror, and a Foley catheter if the procedure is going to be a long one, and then the wires, 22 gauge, 23, 24, 26 wires. Okay, so here is about a 2-minute video on the arch bar application, and this program that I'm using will not capture the sound, but I did put on subtitles for the YouTube video.
Arch bars. Theoretically, the wire is supposed to be inserted around neck of each tooth. The wires should pass interdentally in embrasure around the neck of the tooth. Care needs to be taken not to lacerate the gingiva. But practically, involving each tooth sometimes becomes too much cumbersome, time-consuming, and uncomfortable for the patient and causes more tissue trauma. Therefore, approximately wiring alternate tooth is enough if all teeth are present. In case of presence of edentulous spaces or missing teeth post-trauma or mobile teeth or teeth with compromised periodontal status, more teeth should be involved in wiring. Once the wires are passed interdentally around the embrasures of tooth, we need to orient both ends of the wires. If the mesial end is oriented occlusally, the distal end should be placed apically. The whole motive is that once we place the arch bar, both limbs of the wire should be on the either side of the arch bar. The arch bar is finally placed. The assistant must hold the arch bar in position with his fingers or periosteal elevator when the operator twists the wires. This is done so that the wire tightly clings around the neck of the tooth below the cingulum. Twisting of the wire is done in same fashion as in bridges wiring. Arch bars are indicated for temporary fragment stabilization in emergency cases before definitive treatment, as a tension band in combination with internal fixation using many plates, for long-time fixation in conservative treatment for intermaxillary fixation, for fixation of Avell's teeth and dentoalveolar fractures, and conservative management of condylar fractures. Rosettes are made.
So obviously that just showed what the procedure would look like. So, post-op. So the dressings, you are not going to have dressings, but the wire and or elastic loops, so think like rubber bands that they give to people with braces, those are going to be placed on the hooks that are holding the arch bars in place to immobilize the jaw. It keeps your mouth shut. The wound classification is clean contaminated. Medications, general anesthesia, once again, nasal intubation is preferred since it is a mouth procedure with local anesthetic to control bleeding, antibiotic, ophthalmic ointment, lip ointment, afterwards intravenous antibiotics and pain medication, antimicrobial mouthwash. Since that the jaw is immobilized, the patients cannot eat solid food. They go on a strictly liquid diet. So I researched, and basically, you're getting everything through an IV medically. Post-operative care. So the patient is followed into the PACU with scissors and wire cutters, as well as a tracheotomy. The scissors and wire cutters are if the patient vomits, they can cut open the wire so the patient does not aspirate. If the patient starts to freak out, feel claustrophobic, they'll open it up. They will probably have to go back in and do it all over again. And then there will be no solid food for 4 to 6 weeks. But that is only for the arch bar application. If the patient needs any other surgeries for any trauma, that is a whole different ballgame. So post-op complications, surgical site infection, hemorrhage, and malocclusion. So the arch bar application basically could do opposite of what it's meant to do and just misalign the whole jaw. So these are the questions. And this is the bibliography. Thank you.